To jump back in to my exploration of cognitive behavioral therapy, or CBT, circling back to the article Cognitive Behavioral Therapy's Achievements and Challenges, and the idea that CBT studies produce large effect size improvements compared to control conditions for emotional disorders in adults and adolescents. Looking at the article Why Cognitive Behavioral Therapy is the Current Gold Standard of Psychotherapy, researchers Daniel David, Ioana Cristea, and Stefan J. Hoffman, and I am not reading all of that, published in 2018 in Frontiers in Psychiatry. Taking into account the number of publication studies, academic programs, and/or practicing professionals, cognitive behavioral therapy, CBT, is arguably the gold standard of the psychotherapy field. However, recently some colleagues have argued for plurality in psychotherapy, questioning the status of CBT as the gold standard in psychotherapy, because many studies are of low quality and/or the comparator conditions are weak, thus challenging CBT's prominent status among academic programs and practitioners. We think that many issues factor into the gold standard designation. If gold standard is defined as best standard we can have in the field, then indeed, CBT is not the gold standard, and CBT as a progressive research program would not even argue for such a status at this moment. However, if gold standard is defined as best standard we have in the field at the moment, then we argue that CBT is, indeed, the gold standard. And I will come back to this article in a moment, but I want to reiterate a point from the article Why Ineffective Psychotherapies Appear to Work, which I have referenced in depth elsewhere. In numerous articles, authors have interpreted client improvement following an intervention, even in the absence of differences from a no treatment control group, as evidence for treatment efficacy. For example, in a study of psychological treatment for outpatients with severe depression, a research team randomized participants to receive either cognitive behavioral or interpersonal therapy and found broadly equivalent improvement in both groups. Despite the absence of a no treatment or placebo control condition, the authors conclude that both therapies are equally effective for depression. And here is such a problematic example related to cognitive behavioral therapy, conducted by researchers at Boston University, and as reported in the article The Efficacy of Cognitive Behavioral Therapy, a review of meta-analyses. This is from the publication Cognitive Therapy and Research, 2012. And to emphasize, this is not just a meta-analysis, but a review of multiple meta-analyses on the efficacy of cognitive behavioral therapy. As the authors summarize, despite the enormous literature base, there is still a clear need for high-quality studies examining the efficacy of CBT. Furthermore, the efficacy of CBT is questionable for some problems, which suggests that further improvements in CBT strategies are still needed. Many of the meta-analytic studies included studies with small sample sizes or inadequate control groups. Despite these weaknesses, in some areas, it is clear that the evidence base of CBT is enormous. An enormous evidence base based on what? Mostly comparisons of different mental health treatments to each other, with few studies including no treatment or placebo control conditions. But to continue from the article, Why Cognitive Behavioral Therapy is the Current Gold Standard of Psychotherapy, although a number of CBT trials have included weak comparisons, there are also many studies that compared CBT to strong comparison conditions, meeting the stringent criteria of an empirically supported treatment. Indeed, one set of researchers, Kuipers et al., found that about 54% of total trials for depression and about 20% of total trials for anxiety met the criteria for a strong comparison. Kuipers et al. Further reported that 17% of the total trials for depression and anxiety were of high quality, and that the relationship between the quality of CBT studies and the effect sizes was not strong. Most psychotherapies do not even come close to these numbers in terms of the active status of the comparator and the study quality. These numbers only reiterate the criticisms. If the percentages of studies trials that were high quality were 54%, 20%, and 17% respectively, that means mathematically 46%, 80% and 83%, respectively, were not high quality. Indeed, researchers will point to the mere fact that a large number of studies have been conducted on CBT to highlight how empirically based the therapy system is, such as the authors of Cognitive Behavioral Therapies, Achievements, and Challenges, who in 2008 highlighted the number of clinical trials having been conducted at 325. But if the number of high-quality studies, depending on the type of clinical population evaluated, reaches as low as 17%, that is a serious issue. Nevertheless, brushing past all the potential weaknesses and clear shortcomings, including the patients who do not respond to CBT and or relapse, CBT is repeatedly presented as the empirically based gold standard because, by comparison to other types of therapy, it is more efficacious, effective. In the article, Does the Cognitive Therapy of Depression Rest on a Mistake?, published in 2017, philosopher and clinical psychologist Richard G.T. Gibbs writes, Cognitive behavioral therapy, CBT, is alongside antidepressant medication and counseling today's mainstay treatment for depression in the UK, as it obviously has been here in the US as well. Such treatments tend to work better than nothing at all, yet in general fare a little better than placebo, suffer relatively high relapse rates, and often struggle to provide a complete remission. One reason for the rather low remission and high relapse rates for CBT-treated depression may be that the treatment does not reach to the emotional roots of the problem, that CBT principally theorizes and treats the maintaining rather than identifies underlying causes of depression was acknowledged by Aaron Beck, the American psychiatrist who developed the cognitive aspect of this pragmatic depression treatment in the 1950s. Put another way, to borrow wording from the National Institutes of Health, it does not, like psychoanalysis, mainly deal with the past, but focuses on dealing with cognitive distortion problems in the here and now. As Gibbs continues, much of a psychoanalytical psychotherapist training has to do with developing his ability to make room for and be emotionally touched, yet not inexorably swept along by the patient's transference so he can think about, experience, describe, and help liberate the patient from her unconscious, depressogenic emotional habits. As Beck tells the story, he had a patient who would lie on the couch each session and regale him with lurid tales of her sexual exploits, while he sat back and offered somewhat by-the-book psychoanalytic interpretations regarding the content of whatever it had occurred to her to say. At the end of one session, however, Beck asked his patient how she was feeling. She replied anxious. Beck first suggested to her, in an interpretation focusing only on intrapsychic issues, that conflicts about sex were making her anxious. She cautiously responded, however, to the effect that her real worry was interpersonal. Her worry was that he was bored by her. Beck then began to see that there's a whole stream of preconscious thinking that goes on that the patient doesn't normally communicate to the analyst, especially pessimistic, biased, black and white, overgeneral, irrational expectations concerning what the therapist thinks and feels about the patient. Beck came to call these transference expectations the patient's negative automatic thoughts, NATs, and, drawing on the rational therapy of Albert Ellis, went on to develop a significant range of procedures to help the patients attend to and challenge their NATs. As Gibbs adds, despite the patient's manifest lack of inhibition in talking about sex, Beck still interprets his patient's anxiety, as due to sexual conflict. Moving on, he writes, cognitive therapists are often accused of ignoring the importance of the therapeutic relationship. But as Beck's daughter, Judith Beck, explains, this is false. Cognitive therapy requires a good therapeutic relationship. Therapists do many things to build a strong alliance. For example, they work collaboratively with clients, ask for feedback, and conduct themselves as genuine, warm, empathetic, interested, caring human beings. However, as psychoanalytical psychotherapist Jonathan Shedler responds, this is the kind of relationship I would expect from my hairstylist or real estate broker. From a psychotherapist, I would expect something else. Beck appears to have no concept that the therapy relationship provides a special window into the patient's inner world, or a relationship, laboratory, and sanctuary in which lifelong patterns can be recognized and understood, and new ones created. Shedler's optimism regarding his hairstylist and estate agent perhaps warrants some cognitive restructuring, but his point about the therapeutic relationship stands. This ties somewhat humorously back into what I have already discussed about empathy. Therapists want to present themselves as especially genuine, warm, empathetic, interested, caring human beings. But this runs counter to what the therapist does, or is supposed to do in practice. As Gips continues, a popular canard has it that psychoanalytic psychotherapy is unhelpfully preoccupied with the past, whereas CBT is practically focused on the present. This ignores the way both therapies tend to formulate current disturbance in terms of childhood-acquired pathogenic beliefs. More importantly, it ignores the fact that, at the level of technique, CBT tends to focus on matters arising in the patient's past week, whereas a transference-focused psychotherapist hones in on uncomfortable transference feelings alive right now between patient and therapist. In short, CBT has serious potential shortcomings. Moreover, I would argue, if you steer people away at the outset from all the claims that what a therapist does is just be warm and caring, and point them instead to the reality that, at least in this its most popular form, therapy is about challenging thoughts and beliefs and changing behavior, or that the empirically based support for this same system may not be as strong as some professionals attest, potential clients might not be so enthusiastic about going to therapy. And closely related to this key CBT idea that thoughts should be challenged or questioned, next time I will look in depth at a text from a more traditional psychoanalytical perspective. I hope to see you there.